introduction. Thank you so much. So we're gonna talk about sleep. Sleep is my favorite topic. We all need sleep for survival, and so there's very few things that you need for survival. It's like you need to breathe, you need food, and you need sleep. And so if we think about it, it's a biological function that has been preserved for millions and millions of years in all animal species. And so all animal species sleep. So giraffes sleep 5 minutes at a time. These guys sleep together to protect the group underneath. Otters sleep holding hands so they don't drift apart. Sperm whales have exhibited like sleep behavior where they'll go deeper into the ocean, into this vertical position. It hasn't been proven to be sleep because it's hard to do EEG under the water, under a lot of fat, but it's been described as a sleep behavior. And then birds can actually sleep when they're flying. This is actually a little guy, it's a mite that lives on our skin. I had to look it up. I put the picture initially, and I'm like, oh wait, like does that guy sleep? And it turns out that they use our own like melatonin from the skin, and they regulate their circadian rhythm and their sleep wake according to our own melatonin. So they do sleep. And so when we sleep, there's something called the glymphatic system that actually like gets activated. It's kind of that structure of the brain that will clear and get rid of all the toxins that we produce when we're awake and we're like thinking about the day. And so in sleep, that those toxins get cleared 8 times faster when they've done these studies in rat compared to when the rat is awake. And so, the other part that is very interesting in sleep is that it's not one stage, it's like different stages, right? It's like we go to stage one, two, and deep sleep, and then we go to REM sleep, which is this lateral eye movement sleep. So these are the eyes, your brain waves. And so we are not entirely sure why we have the separate stages. And initially we thought that REM sleep, for example, we block all our muscles. And so we thought, okay, well, it could be for energy preservation. We don't sweat in REM sleep. So that's why, as sleep doctors, we recommend having a colder room because if you get to REM sleep and your room is hot, you will wake up because your body will overheat. And then in REM sleep in rats, it's been proven that it helps with memory consolidation, learning new motor skills, and regulating emotions during wakefulness. But then, they discovered that Komodo dragons actually have REM sleep and they don't regulate their own temperature. And so that kind of busted some of the, oh, well, REM sleep, we don't regulate the temperature, that saves us some energy. So we're still in the quest of why we sleep. And part of it is regulating emotions. This is my middle kid. We're still working on regulating emotions. But it's definitely harder when they don't sleep. And then this is deep sleep, right? So you see these tall, big waves. And so in deep sleep, they've done these experiments where the subject falls asleep. They wait until they're asleep and then they play memory. The subject has played a memory game before, and then the memory game has the icon. And during sleep, when they realize the patient is in deep sleep, they'll play half of the icon's noises, right? So this would be like a storm noise. And then when they do the game again, they can recall the icons that the sounds were played during sleep a lot better than those icons where the sound was not played during sleep. It seems like deep sleep is also very important for memory consolidation and energy preservation. And is when hormonal growth, like the hormone for growth, gets like released, for example. And so unless you're Dolly Parton, who's like amazing and says, she wakes up at 3 in the morning and she does all this stuff, you probably need about 7 to 9 hours of sleep to have sufficient sleep. And so in theory, the total amount of sleep that we need is 7 to 9, because the majority of the people with 7 to 9, you'll fall asleep easy, you wake up on your own, and you feel refreshed. few people that's 5 or 6 hours. Yes, there's some short sleepers in the world, but it's not the majority of the people. So usually when they're saying like, oh, I get 5, 6 hours and I'm fine, it's like hard to believe. And so sleeping less than 6 hours and just the amount of sleep we're talking about increases mortality rates, or it's been linked to an increased mortality rate. And it's been also linked to heart disease, to the point that the American Heart Association added sleep as the eighth pillar of health, or like cardiovascular health. We also know that when we get short sleep, like when we're sleep deprived, there's certain centers of the brain that get activated that are associated with like fear. So when subjects that are sleep deprived are shown the same picture, they recognize the picture as more threatening, even though it's the same facial expression when they're sleep deprived. And also, it's proven that when there's people are sleep deprived, if you're, as a leader, you're less likely to have charisma, like empathy, and so you're more likely to be hostile and abusive. And the same for, co-workers. And there's a lower desire to have social interaction, and to have, there's more loneliness, and like you just want to be alone when you're sleep deprived. And so this is when we're talking only about sleep quantity, right? But then let's say you get enough sleep quantity, the quality of the sleep is also important, and there are medical conditions that affect that sleep quantity, right? So one of those is sleep apnea. Is very common. It affects 1 billion adults worldwide. And so a lot of the patients, ask me, oh, why me? Why do I have sleep apnea? Why do I have, like, how come did I get this? And it's it's a combination of factors, but like what it is when we're awake, our muscles are active and the airway is fine, it's open, we can breathe in and out, no problem. But when we fall asleep, the muscles relax and there is partial collapse, usually behind the tongue, but it's multi-level, or complete collapse, or there's no air coming in or out. And so this would be an apnea. This is a hypopnea. And then multiple events happen per hour of sleep, and that in many patients cause the oxygen to drop or cause them to wake up. So why does that happen? And like there's some risk factors, right? So a healthy individual, you can see a picture here of like an MRI on the side. There is a lot, the black is air, and you can see a bigger column of air. And then this is an individual with sleep apnea. The column of air behind the tongue, it's a lot narrower. So it's a narrower airway to begin with. And obesity can lead to this because there is fat accumulation in the tongue and the soft tissue. So it can narrow that upper airway. But it's not the only factor, right? So especially, in our group of patients, right, that we're supporting, there is mid-facial hypoplasia. So this part of the skeleton may be smaller and may be pushed back. So that will narrow the airway here, like the column of air. Sometimes the chin is a little bit back, and so that can push the tongue back and it will block the airway. And so those are factors in patients with neurologic diseases, or like syndromic diseases that will affect the facial, like bony structure, that can lead to sleep disorder breathing, or like obstructive sleep apnea. And then on top of that, what I love about, sleep disorder breathing, part of it is how the body is impressive. And so the body will make sure you're breathing, okay? And so it's got you, and it will make sure you're breathing when you're awake and when you're asleep. And so that takes a lot of functions, from the cortex, connections to this brain stem, which is in the middle, that has the respiratory center, like control centers. It requires this central brain part to connect to nerves and muscles that are keeping the airway open. And it takes a lot of input from the body, like how's the body? Are you breathing too much? Are you breathing too little? And that all gets like inputted and processed, and a response goes out dependent, so to keep an equilibrium. So obviously, there is some patients that will just wake up too much before they even can establish a nice upper, airway tone, like the muscle that to keep it open during sleep. There's patients where the muscle is weaker, so it doesn't respond as well. And so those are factors that even when you may not have obesity or like the traditional risk factors for sleep apnea, you can still have sleep apnea. And this is what it looks like on a sleep study. So if those of you that have had a sleep study, you know, it's a lot of cables. We have cables near the eyes, the brain, EKG. We measure your breathing, chest, abdomen, belts, oxygen. We measure snoring. And so this is what it all looks like on a screenshot. So these are 30, 30, and 30 seconds. And what we're seeing is that there is this flat lines, and in those flat lines, those are nasal cannulas that are measured like hot air, hot, cold, hot, cold. There's like no air coming in or out. But the chest and the abdomen they're trying to breathe. So there is chest and abdomen movement, but no air movement. So that means the airway is closed up. And then there is an awakening, is this fastest EEG brain activity. The chin, the muscles get activated. You have a loud snore. And then you breathe again. The patient is breathing, but you see this 1, 2, maybe 3 breaths, and then they block the airway again as they fall asleep. They're like, oh, we breath. Okay, then we fall asleep, and the airway blocks again. And then you see that the oxygen drops, right? Because you're not getting any air. So, and this is one of the reasons I tell my patients, like, I can put 100% oxygen on your face, but if your throat is closed, it's not going to get to the lungs anyway, right? So that's why we cannot treat obstructive sleep apnea with oxygen. That would be a lot easier, but no, we need like pressurized air and mechanical treatment to relieve this obstruction, keep the airway open, kind of like a bouncy house. And then the patient can fall asleep or not waking up constantly to breathe. Because every time you choke, right, with obstructive sleep apnea in particular, you have this intermittent low, high oxygen, high CO2, chest pressure swings. There is like a stress response activation every time because, you know, your body is going to keep you breathing and alive. And so there is inflammation. And that is what links the obstructive sleep apnea to not only sleepiness, right? Because if you're sleepy driving, that's a huge deal too, for example, or sleepy at work, or sleepy when your family, you know, is interacting, or you're doing an activity that you enjoy. That's a huge problem. But even if you're not sleepy, that has risk of heart failures, arrhythmias, or even sudden cardiac death. So it really affects the body at all levels. It's like Goldilocks waking up to the bears, right? It's like all of a sudden this response. I imagine that response several times per hour. And so we were talking about right now, like, oh, do you have sleep apnea? Oh, I don't know. Like, obviously, you know, there's some symptoms that are linked. So snoring, sleepiness, dry mouth, choking and gasping. If you have choking and gasping, then it's like, yeah, that we need to look it up. It's probably sleep apnea. But it's rare to get that. It's not so common because it's like the more severe patients. But there are other identifiers, right? So dentists, for example, they may identify patients that have this teeth indentation. So that means like this tongue is almost like too big for the bony face. So that's one. The other is like your tongue may be folded. So again, maybe this skeleton part of your face is small, but the soft tissues are big. So that means that, you know, it's a limited space. The airway is going to be narrow. When you sleep, they like muscles relax and you block more. And then, you know, in patients with like syndromic like conditions like craniosynostosis, you may have like, again, the smaller cranial like facial structures are flattened, so the airway is narrower to begin with. So a lot of patients, like children with craniosynostosis, have obstructive sleep apnea. In all these patients, these are some of the slides I took from Dr. Baruti, which we work with together, one of our ENT pediatric doctors. You know, in pediatrics and children, they tend to have the bigger tonsils. So this is, for example, they're kind of big, but not reaching the midline. And these are grade 4 tonsils, which we call like kissing tonsils, or they're kind of like completely blocking the airway. So in pediatrics, in some patients, if you remove this and then you open up the space and the sleep apnea is treated. In adults, it's not so easy because there is usually also like that muscle floppiness that causes the collapse. And so in patients, even with like craniosyndromic, like let's say craniosynostosis or Pierre-Robin or other syndromes that affect like craniofacial structures, we could start with removing the tonsils and opening up the airway a little bit to see if we relieve some of the obstruction, and that may treat obstructive sleep apnea. And so we do assessments with x-rays, and again, black is going to be air and very white is bone. We will assess the craniofacial structures, and we can see the column of air and see if it's narrowed and if it's affected by, some of the position. And we're also assess this little bone here is the hyoid bone. In some cases, we can kind of pull it a little bit towards the chin and open up the airway that way. And so in pediatrics, and especially like craniosyndromic patients, there are some surgical interventions that have proven to be very effective. And so tracheostomy is one. We essentially just put a tube in the neck directly to the airway. So then you bypass all the upper airway, the upper stuff. And so if it's open, you don't have sleep apnea. And then these are some of the other like surgical interventions that can be done. And we'll go a little bit over some of those. And so in more recently, we're very excited because there is the Inspire. Inspire, I call it, it's like a pacemaker for the tongue. And it's implanted under the skin, but it gets activated during sleep and can move the tongue forward. It was approved for patients with Down syndrome. And so we're excited because many of these patients struggle to tolerate a mask on their face. And their tongues are wide and big. And so this device, you can have a caregiver activated when they go to sleep, and then the device will be kind of activating the muscles so they don't choke the patient. And you can treat sleep apnea. It has been approved for severe obstructive sleep apnea, even in pediatrics, is for patients with Down syndrome. And so before we get to these interventions where we're trying to open up the airway space, they'll do a direct visualization. So we want to see this is kind of coming from the nose to the back, and this is your glottis, these are the voice box, this is kind of like the back of the tongue, and then we'll see if there's a lot of big tonsils, if this is like floppy and long, and so they can tell a lot from just looking at the airway in these patients, kind of deciding what surgical intervention could help the most. And so in this patient, the glottis was too long, so they can kind of tie it a little bit up front, and then they can open the space that way. And then there's some times where, there is a narrowing. In like this case, you see this like bulge in here. It seems like a little too much. It's kind of blocking that airway. And it turns out, this patient did have a kind of a nerve tumor that was resected. And then after they took that out, they had opened up the airway and the sleep apnea resolved. And so the evaluation is very carefully done, not only with a sleep study, but also with imaging to see how the airway looks like, and then what potential causes are for the sleep apnea, especially in pediatrics and patients with craniosyndromic, that are craniosyndromics that may have blockages in certain parts. And then based off the diagnosis and the condition and the cause, you have like the potential surgical therapies. And, it is invasive. So it's usually reserved for moderate to severe diseases. And, but at the same time, if there is an intervention that is surgical, after, if it's improved, and then you don't have to like adhere or use the machine every night all night, right? So it's like a one intervention. And then there is specifically in Pierre-Robin is a syndrome where the chin is smaller and it can compromise the airway significantly, and these patients can have a tracheostomy until they do surgery to advance the chin. But sometimes they can also just do keep the tongue kind of tied more frontal, like they'll do a suture and keep the tongue outside to open up the airway in the back. And they'll make sure that it's fitted. So like this is the workflow for our Dr. Reed, who's a like a plastic surgery doctor, and Dr. Barudi, who manage our patients from pediatrics to adults, and they're wonderful. So like the amount of multidisciplinary evaluation that goes on is like just impressive, and it always makes me proud of like working at U Chicago, because they'll do a very careful evaluation, looking with the camera, looking with CAT scans, and trying to figure out that the cause of the sleep apnea, making sure it's safe with the oxygen, with the CO2. And then in these patients, they'll like kind of break the bone here and advance it, and it just heals as in a longer position. So they essentially, will kind of do this imaging and 3D planning, and based off of that, create this like 3D printed devices that will make sure that the jaw is advanced properly, and you can see, like the huge difference that that can make, and how then that airway opens up, and the patient can now breathe and feed and do really well. So in this pediatric patient, they had stopped breathing 39 times per hour from choking, and then after the surgery, that's like down to 4. And as they grow and the airway grows, that's gonna drop even more. And then they do follow up imaging to show like the bone changes. And so because as the kiddos grow, you want to make sure that the mandible is also appropriate for their new sizes. That's a little bit of the difference between kids and adults. So I like the kids are different at each age, and like so for me, adults are like easy because you're just my adult, and so I admire a lot of what they do. Um, and so that's for pediatrics. And obviously, for pediatrics, their numbers are a lot lower. So in adults, less than 5 events per hour is considered normal. And for pediatrics, it's less than 1 per hour. So 1 to 5 is mild, 5 to 10 is moderate, and more than 10 is severe. For my adults, it's like less than 5 normal, 5 to 15 mild, 15 to 30 is moderate, more than 30 severe. So there is a little bit of a difference. So for my adults, right, like how do I know if I have sleep apnea? And this is something like you can scan and do it yourself at home for fun. But if you're snoring, if you're tired, if you have high blood pressure, already 3 points puts you at an intermediate level of risk. We would want to test you to see if you have sleep apnea. Less than 2 is like, okay, you're unlikely to have it. You don't need testing. But, male gender, having a thick neck, being older than 50. So as you can imagine, more than 5 to 8 is high risk. It's like if you have yes, every yes is 1 point. So if you have 5 to 8, you need testing. You're at high risk. And the higher the points, the higher the severity of the sleep apnea, probably. So the only way to know is doing a sleep study for sure. We have a sleepiness scale, but that's not very helpful. I hate it when my fellows are like, they're not sleepy because the scale was less than 10. It's like, but in women, this has not been validated. So I may not be dose enough everywhere, but I still feel sleepy. And so that doesn't deny me of you're feeling sleepy. And so I love this patient and says, yeah, I'm sorry, but this survey does not indicate anything of value. And it's true. It's like it hasn't really been validated for everyone. So we have to be careful with what we use, especially in women. It presents atypically. It can present with more unrested sleep, insomnia, headaches, anxiety, irritability. Like bed partners tend to not be as watchful, be like, oh, she stopped breathing, oh, she's snoring, because like women are more like caregivers, right? Like they're constantly like watching their children or their husbands, or like but men tend not to be as attentive, and so a lot of the night symptoms may be missed. And so even when women have the typical symptoms, they're less likely to be referred for evaluation or treatment, despite having same risk factors. So my women out there, advocate for yourself and others, make sure that you're getting evaluation. And then we talked about the testing, the formal testing we do in patients. It's usually the in-lab sleep study, right? So you come around 8, you wake up at around 6, and then this is all the cables that we do. But now we also have home testing. So for patients without a lot of medical problems, like we're not concerned about centrals, which is just pauses in the breathing, or high CO2, shallow breathing, then doing a home study is it has been demonstrated to be non-inferior. Now, if the home study is negative and it doesn't make sense, we can always follow with an in-lab. So many patients are doing home studies. In this case, it's just a finger probe, a watch, and a sticker on your chest. And then this is another device. It's a night owl, can test 3 like nights in a row. And now the more and more devices are coming up. We're not using this in clinical practice, but this is one that goes under the mattress that can detect events. We have the Apple Watches now these days that are detecting moderate to severe sleep apnea and giving you a warning. So it's like good to get tested if you have one of those alarms. And then there's even smaller devices that are coming out and approved by the FDA to detect and diagnose sleep apnea. We know about the rings. Who has a ring? Anyone has one of the rings? No? Oh, look at you guys. Okay, good. So the rings are good. They're not perfect. I've had patients that had like very low oxygen scares, and then we bring them for testing and their oxygen is fine. They're not medical devices, but it's good to trend over time. And also like their sleep staging is not great. So don't get super stressed out about like, oh, I'm not getting enough REM sleep or deep sleep because it's not very accurate. When we're talking about treatment, this is the inventor of the nasal CPAP, and these are the first studies. So if you're complaining about the mask, think about this guy who avoided a tracheostomy, but had to glue the mask every night to his face. But it worked so well, he could go back to work. So this is the initial studies. They actually used this, like made their mask and then had a study showing that when they turn it off, you patient had drop oxygen come back out, oxygen drops up, drops back. So like these are all the sleep apneas. When the device is on, the oxygen was fine. And so they demonstrated this multiple times and they use a reverse vacuum cleaner power like rotor. So this is how CPAP started, but imagine this is a huge invention because it paved the way for BiPAP too. So patients like polio would need to live on iron bands or being ventilated with a tracheostomy. Now I have patients with ALS that can't breathe 24/7 with their mask on BiPAP machines that are helping them breathe. So this is huge. Obviously, now we have a lot of advances. This is what happens when I forget to type CPAP and I'm like, just put full face mask. Then my patients are really scared. But we have a million masks on the markets, and at the end is whatever mask that works, but it has to fit. That's what we were talking about. Like if it's a pressurized air treatment, so if it's not fitting well, it's going to be very uncomfortable, drying, and it doesn't deliver the pressure. So it's like what I was saying, like you might as well have a fan on your face. You need to make sure that mask fits well. And then nowadays we're coming up with more 3D printed masks. I have some patients where the face is not typical, right, to the masks that are out there, like maybe flat noses, they like here, or like smaller face, like mid face. And so we're excited about the development of these 3D printed masks. And this is an option if anyone is struggling. I really like these masks. I saw them in Brazil, but they actually in a conference, but they actually are made here in the US, and they're moldable. So you can like pinch them and they keep that straw, or you can expand them, and it has a gel. So they're hard to get through DME companies, but that's an option for patients that have difficulty with mask fits. Now we have devices that can, tell you what mask you need, and I monitor my patients. So I'm like the FBI. My patient today was like shocked with like ALS. I'm like, how did she know all these numbers? And I'm like, ooh, I have it all here in the cloud. And I can even make changes online. And that's very important because I had this patient, for example, that's doing great, and then all of a sudden, a lot of sleep apnea events. Turns out this patient has a house in Aspen. When they go to high altitude, they just have central apneas and stop breathing. So it is important to make sure that your machine is effectively treating their breathing. And then in patients with, we're talking a lot about obstructive sleep apnea, but central apneas, this is what they look like. So it's still pauses, like there's no air coming in and out. But it's not because the airway is choking, it's the airway is nice and open, but it's just like the brain is not sending this signal to breathe. And this is what the chest and the belly look like. So a lot of our patients with, this is a patient with Arnold-Chiari malformation. This is like a smaller posterior fossa, so it presses on the respiratory centers and they just have this irregular breathing pattern, and that can wake a lot of patients. So initially the treatment is surgery, so they'll decompress, so they'll open up the space, and you see the post picture here. So here is narrow and pressed, and here is nice and open, and there is a lot more space in the posterior fossa here. But this patient still had pauses in their breathing. So for those patients, we have what we call BiPAP machines. So that when you breathe in, it gives you a higher pressure. When you breathe out, it gives you a lower pressure. And if you're not breathing, it will give you a breath. The CPAP doesn't do any of that. CPAP is like a bouncy house. It just like pushes the same air. So it's just keeping your throat open. This will keep your throat open, but it also will give you a breath and will help get you more air. So in a patient that has these patterns where they're just not breathing, the machine will do this, will like give you this in and out pressure, and that will help you move air during these events. And then that's how it treats central apneas, because it'll give you a backup respiratory rate. And it can also treat in this specific machine obstructive apneas, it will self-adjust. So some patients with especially with neurologic conditions, may need a BiPAP. So BiPAP is two pressures or bi-level positive pressure, and they'll need a backup respiratory rate. So we will assess that usually in sleep studies. Now, we know that there are patients that cannot tolerate BiPAPs or CPAPs, and no therapy is for everyone. So you go to your doctor, you get support, you try different masks, but there is a point where you have to figure out if that therapy is for that patient. So there are other treatment options, and there are not too many. Oxygen helps some patients with central sleep apnea, but this is a pacemaker for centrals. So it's called Remede, and it's installed. Now I'm talking like you're robots, like we're robots. It's implanted by our cardiologist, and then it will activate this muscle to breathe, like just pace it, and that's when you lay down. So we have few patients with this machine. There are few traps out there, like this micro CPAP doesn't really treat sleep apnea well. Occasionally someone will come up with this like nasal trumpet, like, oh, guess what, yeah, it can treat mild sleep apnea a little bit, but it's poorly tolerated. It's like, I could have told you that. No one likes to have a nasal trumpet in their nose all night. Obesity is a huge issue. So obviously we're very proactive about treating obesity like a medical condition. It doesn't help when patients are told like you have to lose weight. It's like, oh yeah, I knew that. But it's more like there are medications, there's surgery, there is like obviously lifestyle intervention, but like this stage is very important. We treat it like diabetes or thyroid. I'm not telling my thyroid patients to go get treated, like figure it out. Positional devices. Some people just have sleep apneas and they sleep on their back. So trying to avoid sleeping on their back. Usually this is in combination with something else. There's some mouthpieces. This is for obstructive sleep apnea. They move the jaw forward and open the space in the back. It's usually for mild sleep apnea. It has to be custom made, titratable, adjustable by a dentist. So they're like $5,000. Sometimes they're paid by insurance, sometimes they're not. And so not like the $80 ones for snoring. So these are like made by dentists. And this is just approved for pediatrics. And so I don't have a lot of information, but excited to have more options for pediatric obstructive sleep apnea. Essentially like opens up the space in the palate to allow to have a bigger airway, especially as they grow. This is like a new kid in the market, probably in 2023 already, but it's like a TENS unit for the tongue. I don't know if you remember like those exercise things that will electrocute your belly and then you don't have to exercise. It's the same like for the tongue. So in theory, it makes the tongue less tired. So it resists longer overnight. It's for mild sleep apnea. And then in the past, we used to do this a lot. We took the uvula out, the tonsils, everything. Now we realize the uvula, which is that little thing that hangs here, is actually needed for like speech and swallow. So some patients are having a lot of, like, if you drink, it comes out of your nose, and it's not nice. So now they just shave it now. But we do have patients that sometimes get just soft tissue, like they cut it and open up the space. And then we have mandibular advancing surgeries where more involved. They make sure the teeth are aligned, bites are aligned. So it's a long process and it's about a month of healing time, but can be very effective. So they'll break the bone, open it up and fix it. And then, the bones heal and will kind of cover up the space and you can advance. So I have few patients who have sleep apnea that have CPAP and then they get the surgery. So planning for treating the sleep apnea with the surgery can be a little bit of a challenge. So we group and discuss what we're going to do for that. And then, there is tracheostomy, which is that tube here. It's very morbid. It's rarely done. And when it's done, sometimes it's just as a bridge. While they get the surgery, they heal and then they can use the mask again. This is kind of just like that looking at the airway. So they'll go with the scope through the nose. They'll kind of advance to the back of the throat. The patient is asleep. So it's a drug sleep and like it's a drug induced sleep endoscopy. It's like getting a colonoscopy, but for your airway. And then we see how your throat chokes you. So obviously there is an anesthesiologist in the room. So it's not like Michael Jackson doing it rogue with propofol. It's like controlled. And so, but we are kind of looking to see how the airway chokes. So if it's front to back or in the sides, and then we look like behind the airway, this is a patient that actually is getting some CPAP treatments too. And you see how narrow and like that's the snoring. When you see that vibration, that's when like people are snoring. And so this is when the jaw gets advanced manually. You see how much the airway opens up and so it's like, oh, maybe an oral appliance will help. But then when it's released, it chokes again quite fast. This is that Inspire is the pacemaker for the tongue. This is for obstructive sleep apnea. There's a new device that is going to be approved any minute in the States. And then this is us adjusting those devices, activating the tongue and adjusting the settings. Some patients need both an oral appliance and an Inspire device. And then in some cases that we have like pediatric patients, cognitive issues, cannot tolerate any mask, have had surgeries, like we've limited a lot of the treatments. We can do high flow nasal therapy. It's not paid by insurance, so it's like tricky to get it approved for. But I think it's slowly getting more, we're publishing more studies, so it's going to get there. So it's like 40 or 50 liters or 30 or 20 liters of air that you can bleed oxygen, but it's this air that will help kind of wash out this airway. It has to be heated and humidified to be able to tolerate it. So it needs some special machines that we can deliver that at home. But it's a potential for treating sleep apnea in patients, pediatrics, especially with a lot of syndromic issues. So that's all I had for you guys. I know it was a lot, but every animal species sleep. You don't even need a brain to sleep. Like the jellyfish sleep, like demonstrate sleep behavior. So keep the quantity in mind and make sure you have good sleep hygienes. Make it a priority for you because people always take up from sleep, right? Because we're doing so much stuff. But also, the quality is important as well. So obviously, we're here to help if there's any need for testing or treatment.